Alrighty. Are you able to see that okay?
Yes, I am.
Okay.
Can I move the slides, or I would just request you to move the slides? How does it work?
So with me pulling it up, I'm gonna have to advance the slides, but please just let me know when the next slide and I'll do that for you.
Sounds good. So, again, welcome to everybody on early Monday morning after a beautiful weekend. I can understand if you're a little tired and sleep deprived with REM sleep. But I think that the topic is quite interesting and also important in light of what we are going through. Since the pandemic started, it's been widely recognized and acknowledged that the care for non-COVID patients has been complex. And it was with this singular purpose that ATS constituted a task force under Dr. Kevin Wilson and several experts across the country to look into some diverse set of ideas and solutions and to channel them as a consensus document as to the best way to get back on our feet with the care of these non-COVID patients. So it's been a privilege and an honor to be part of this task and representing WVU and West Virginia's voice in this task force and their recommendations. So a couple of things, just wanted, having an insight of this documentation preparation over the last 2 months. The title somewhat doesn't do justice to it, because if you look at the title, says pandemic lessons, but we are anywhere close from the pandemic being lessons. So the idea, the task force recognized very early during our early meeting somewhere around mid-April that this disease is going to be vaccine and waning, and COVID-19 is here to stay with us for a long period of time. So they're not necessarily designed when the pandemic lessens, but they are basically designed in order to have a mechanism of dial up and dial down as the pandemic goes up and down. It also is purposely broad-based to accommodate the wide regional differences of the prevalence that we are noticing across the country. So having said that, we can move to the next slide, Smita. So as you are all aware that CDC in March 2020 recommended cancellation of all elective medical services in response to the COVID-19 pandemic. And as I alluded, that led to a backlog of patients with non-COVID diseases, and there was a sense that they are suffering because of significant purposeful orientation of our efforts towards COVID-19. Next slide, please. Next slide, Mitchell. Oh, thank you. So in response to that, the ATS formed a task force somewhere middle of April. Took us about good 6 to 8 weeks to hammer out a consensus across the country as to how we will deal with non-COVID patients, either when the pandemic is lessening or if it is waxing and waning. Next slide, please. So the goals of this task force, as we looked at it, was to, one, protect our patients and staff from exposure and viruses. The last thing we wanted to do was increase the transmission of the disease in the community. The other one was to account for the limitations in staff, equipment, and space that are essential for the care of COVID-19 patients. So the priority still being COVID-19 care. We wanted to see how we can release the rest of the resources towards non-COVID patients. And then obviously provide access to care for patients with acute and chronic conditions who may actually suffer and get worse while our attention is focused on COVID-19. Next slide, please. As I alluded also earlier, that there was a sense of caution that it is unlikely that the SARS-CoV-2 virus would lessen over the next months, and it is here to stay. And what we're going to see is a waxing and waning process. So in the wisdom, which I was pretty impressed with, collective wisdom, this was one of the earlier thought process going through that this is not something we're going to see the end of in the next few weeks. And we need to somehow construct this document which overcomes this obstacle. So operating procedures should frequently be reassessed and modified. And this was kind of the key mechanisms that we wanted to incorporate into this document. And that's why some of these baseline recommendations are a little bit broad-based and are unique because they can be adjusted to local prevalences and institutional differences across the country. Next slide, Mitchell. So as we are all aware that CDC also had recommended that elective in-person services can only be started after CDC gating criteria have been satisfied. We call them the 3 C's. The first C was the number of cases. So what you have to, or community has to demonstrate, is a downward trajectory of COVID-like symptoms and influenza-like illness over a period of 14 days. The second C was the capacity and the capability of an institution and a hospital to treat non-COVID patient because of the redirection of resources towards COVID-19. And the third C, which we really thought was that our biggest asset is a healthcare worker, and we should have a robust testing program at the healthcare workers. The last thing we wanted to have healthcare workers transmitting the disease to very vulnerable population within the domain of a hospital or a health. Just a quick word on the downward trajectory. Confirmed this was a 14-day period, so just a few days of downward trajectory was not sufficient to start this process. And I'm going to show you what the downward trajectory, how it was defined in the next slide. Next slide, Richard. So this is CDC and CMS recommendations about the downward trajectory of the cases or new case reports. And the first one basically is the new cases, which are variable day to day. The problem with the first trajectory was as the number of tests were being ramped up, this could give a spuriously high number and did not account for the case rate. So we thought it more prudent to use B or C. The B is basically a surrogate marker for hospitalization. So we believe that as the prevalence in a particular community increases, the hospitalization of these patients would also increase. So if you can show downward trajectory of hospitalization in a certain community, we thought that that hospital, institution, community was ready to refocus on non-COVID care in a serious fashion. And if this marker or this data was not available, we recommend C, which basically meant that new case reports averaged across 7 days. So that kind of took into account if the number of testing was increasing or being ramped up in the community, that it does not give a false impression of increasing new cases. Next slide, please. The second pillar of taking care of non-COVID was prioritization. We are all aware that because of COVID-19 care, all resources being redirected in that direction, a large number of backlog had been formed as far as the non-COVID patient care is concerned. So how do you accommodate such a large case number, especially when the resources available are limited? Physicians are focusing more on COVID-19. So the recommendations were that we break down the patient care into different tiers. This is again CDC guidelines. Tier 1 was mostly stable patients coming in for regular follow-up, and then the increased acuity was tier 2 and tier 3. Tier 3 was defined as somebody who, if it was not seen or taken care of, would most likely end up having a bad outcome. And on the x-axis, you can see, I'm going to apologize, cut off a little bit, but it basically means the prevalence. So these two dictated the care of non-COVID patients. As the tier of disease severity rose from tier 1 to tier 3, it was much more likely that these patients would need a face-to-face follow-up with your physician or workup as opposed to tier 1. And then as the prevalence mitigated, that as the prevalence increased, there were more chances that the tier 2, which was dependent on the discretion between the provider and patient, would move more towards telehealth rather than face-to-face visits. So this is a good overall chart for most institutions to have and follow, and that's what we are doing here at WVU in Morgantown. Next slide, Mitchell. So let's go in for ambulatory clinic care, and for ease of discussion, I have clubbed everything pulmonary sleep into an ambulatory clinic visit. And what we believed was that ideally these patients should be well screened before decision to face-to-face is made. And ideally 72 hours before the visit, these patients should be contacted over the telephone and be screened for any symptoms of COVID-19, visitation to any hot areas, recent travels or recent exposure to COVID-19 patients. Once it's been confirmed that this is not true and patients screen negative, we had recommended that the patient be screened again at the check-in time in the clinic as to have development of any new symptoms during the interim or any exposure to anybody who's had any kind of symptoms. So patients, in case they were found to have new symptoms or it was found that they were COVID positive or by an outside test, they were directed to a different, more safer waiting area and directed to a nearest center which was doing COVID testing. Next slide. Mitchell, next slide. Mitra, can you go on to the next slide? Yes, thank you. The other thing which was very important, and the task force wanted to re-emphasize, that there's a significant amount of indoor possibility of transmission, and the waiting areas should be decongested, and patients should be waiting in the parking lot until they are called in for the appointment. They should avoid being accompanied by family members. The family members are supposed to have them drive all the way up to the clinic, but then leave them at the door for the appointment and then pick them up once they're ready to be driven back home. And then a third criteria, which may or may not be possible in every institution, was we felt that a unidirectional flow of patient would be safer in these times. What we meant by unidirectional or laminar flow of patient was that the check-in counter should be different than checkout counter. In case the patients who are seen inside and they felt that this patient could be having some new symptoms or maybe an asymptomatic carrier is not on the way back, mingling back with the patients who are coming in. So you decongest the check-in area and you have a laminar flow where patients are moving from point A to point C without interacting with each other. Next slide, Mitchell. And this follow-up surveillance was very important part, and I think the crux of the recommendations as I take you back to our original talk about how this pandemic is not going anywhere and it's going to dial up and dial down, and we need to keep in step with these recommendations. So follow-up surveillance was basically a mechanism of the Institute to keep an eye on what's happening in this microcosm of their world. So the patients who were instructed to contact the clinic if they developed new respiratory symptoms within 14 days of their visit, or they were diagnosed with COVID-19. So that was their cue that, listen, something may not be going right, because although the state levels seem okay, the national levels seem okay, our rates seem to be a little off. Let me give you an example. You know, let's say the national rate at this time, or West Virginia rate for positive cases is 4%, and your clinic starts seeing 10%. Then there's something wrong which needs to be fixed, and these processes need to be re-examined to see why your clinic, your institution, your medical facility is seeing such a larger number of cases. We also recommended, this was a little softer recommendation, is that if human resource permit, that we shouldn't be banking only on the patient goodwill to contact us within 14 days, but an institution should allocate some resources to reach out to these patients in roughly 2 weeks period of time as a follow-up to ask whether they had developed any symptoms of COVID-19 or they have been diagnosed in the interim with COVID-19, which would then be taken into consideration, strengthening your processes of taking care of non-COVID patients. Next slide, please, Mitra. And it was very important for us to emphasize that there should be an assessment of operational success. Operational success was defined by the task force as absence of any viral transmission, ability to handle patient volume without exceeding social distancing constraints, and more importantly, lack of delay in patients' flow, resulting in bottlenecks. So once all of these were satisfied, we felt that the clinic could then go up on increasing the number of patients they are seeing inpatient, because they have all the necessary tools and the mechanisms to take care of these patients. And this assessment and operation tool, we emphasize, shouldn't be just a one-time deal, but it should be iterative and frequently being assessed at least on every 2 to 4 weeks period of time. Next slide, Mitra. We also wanted to ensure that there are staff considerations, that staff should receive proper PPE training. We all know that donning and doffing is not simple a procedure. In fact, many of the viruses transmission occurs during the doffing process. And a lot of folks who are not well trained can actually easily transmit the virus on the doffing process. These staff should be screened daily each time they come in the morning, so that they don't become the nidus of transmission. And if symptomatic, these people and staff and people working in the healthcare environment should be tested and properly quarantined. Next slide. Return to work. So when a staff is either symptomatic or test positive, how do we get them back into the work stream was an important thought process because of the shortage of healthcare workers in many areas. So we came up with a test strategy and a non-test strategy. And this was based on input from different regions. There were some regions which had ample testing opportunities and kits, and others who were struggling with having ample kits to test, COVID-19 patients. So in the test strategy, we wanted to ensure that there was lack of fever without taking any antipyretics for at least 3 days. There was improvement. It doesn't have to be total resolution, but improvement in respiratory symptoms, that your cough is getting better, you're not that short of breath, you're not that wheezy. And then you had 2 negative COVID-19 tests more than 24 hours apart. So it's important that they should be more than 24 hours apart. In case the patient was tested COVID positive but was asymptomatic, those patients could return to work after 4 to 5 days, and as long as there was 2 consecutive negative COVID-19 tests, again, collected more than 24 hours apart. The non-test strategy was for regions who are struggling having enough kits for the testing. And these strategy included the patient being free of fever for at least 3 days, again, without any antipyretics. At least 10 days have elapsed since his first symptoms appeared. And patients are asymptomatic positive patients also need to wait for 10 days before they return to work. Now, these are, of course, guidelines which are not infallible. One of the issues with the test strategy we noted, looking at the literature, was that in high prevalence areas, there is also a higher prevalence of false negatives, which means that you could bring people into the workforce while they're still positive, but because the test is falsely negative. The same is true for non-test strategy, that bringing them 10 days down doesn't mean they're not non-infectious, although there was some data, not as robust, which said that even if you're shedding after 10 days or 14 days, those viruses may not be viable, and these viruses may not be infectious, although you may detect it in the DNA testing. So those were the crux of the recommendation for return to work. Next slide, Mitra, please. So moving on now from a clinical domain of patient care to very specific areas which we deal with as pulmonary critical care, one of them being pulmonary function testing. We recognize that this is a high aerosol generating procedure, and the spread can also occur from asymptomatic individuals, since we are making them breathe heavy, sometimes invoke coughing and hacking, and all of these are conducive to easy transmission. Not to mention that there's cross-contamination, since there's so much equipment, testing rooms, waiting areas, all of them within the context of a very highly vulnerable population. Next slide, Mitra, please. So I think we wanted our audience to ask themselves a few important questions. One of the important questions was, how important is the test for diagnostic management of this patient? Let's say as a pulmonologist, I have a patient who's been relatively stable over the next 2-3 years, and he comes to see me and we get a yearly PFT to see the progression of the disease. He's 72 years old, and I call him and he's been doing great. Now, is it really necessary that that yearly PFT would make a radical difference in my approach to his treatment, or would impact his health? I would argue it may not, or it should not. On the other hand, a patient who just had a lung transplant 6 weeks ago is having more shortness of breath, and we are suspecting bronchiolitis obliterans, which could change the outcome of this patient. Absolutely, that's a patient we definitely would want to get that. So those were, I think, that the issues which we left to the medical directors and physicians to say that, listen, please be cognizant of the people you're bringing to the lab. Make sure that that test, there are more benefits, and the benefits outweigh the risk of transmission of the disease. We also wanted to make the pulmonary community and the respiratory community more cognizant of which we felt high-risk procedure. For example, methylcholine challenge tests and exercise challenge tests, including cardiopulmonary stress testing, are considered much higher risk for transmission of the virus than a simple spirometry, a 6-minute walk test, or lung volumes DLCO done within the constraints of a plethysmography, plethysmogram, a box. So these would, I think, be our natural choices to gravitate. And I think the natural tests which we would like to put off for now, especially in the time when there's a surge going on, would be the methylene challenge and the exercise challenge test. Thank you, Mitra. Can we go to the next slide, please? Okay. Bronchodilator test. In itself, they may not be that difficult or high risk, but we know that nebulizer treatment can aerosolize the viruses much more than non-nebulizer treatment. And there are many, many labs who use nebulizer as a part of the bronchodilator test. So we wanted to make sure that the labs are cognizant of it, that if a bronchodilator must be performed, it is better to use an MDI inhaler rather than go for a nebulizer. If they don't have access to MDI, then an actuated nebulizer may have a lower risk than a regular nebulizer. Next slide, Mitra. Thank you. So some of the PFT lab strategies, and I apologize, this little busy slide over here, but our recommendations included that in areas, especially where there's no dearth of testing equipment and testing kits, that these patients you bring into the PFT lab be tested for SARS-CoV-2 virus within 72 hours of appointment. Again, these are all recommendations for high prevalence regions. In low prevalence regions, we recommend that these patients, very similar to what we have recommended in an outpatient clinic face-to-face visit, is screened telephonic visit before the appointment and again at the time of the PFT testing. We recommend that the PFTs be done in a negative pressure room, and these can be easily formulated these days, with very minimal, financial burden. We recommend inline antibacterial and antiviral filters wherever possible. Patients are recommended to wear a surgical mask during these tests, unless you're doing a spirometry or actually inside the body box. We also recommend the staff wear proper PPEs, especially N95 mask, face shields, gowns, and gloves, because it's a highly aerosolized environment. Both patients and staff should wash their hands after testing, because a lot of folks would cough in their hands or their on arms, and that could lead to touching of the equipment and then transmission of the disease. We highly recommend that the room should be disinfected between patients. And also, we wanted to consider concomitant use of HEPA filters and UV decontamination of the PFT lab in locations where this is possible. There was also recommendations that for patients who are not that urgently required and whose diagnostic ability would not change to bringing in the PFT, that these patients could be considered for home spirometry. And there have been studies published about home spirometry compared with in-lab, and have been found to be adequate in monitoring these patients remotely. So just like peak flow, home spirometries can give you an idea about FEV1 and FVC and can help you adjust the medications remotely through telemedicine. Next slide, please, Mr. So bronchoscopy and procedures. Similarly, bronchoscopy procedures are pretty high risk for aerosolizing this virus. So we recommend using a priority scoring system, which has been developed, called the Medical Necessary and Time-Sensitive Instrument, MENTS in short. And this is a bunch of 21 parameters, each one given a unit of scale of 1 to 5. So you could have anywhere from a score of 21 to 105. The higher the scale, the more sicker the patient is, and more the need for the procedure. So all patients should undergo testing in advance, no more than 5 days before their procedure. And bronchoscopy, especially percutaneous tracheostomies and e-buses, should be performed in negative pressure rooms. A minimal number of necessary providers should participate and should be trained in donning and doffing procedures. And this is an area which we also recommend hair and shoe covers. Again, re-emphasizing a very minimal amount of experts who are absolutely needed should be in the room. So we recommend residents, medical students, staff which actively necessarily needed for the procedure not be present at that time. Pleural procedures, on the other hand, may be performed outside a negative pressure room with basically a HEPA filter and proper PPEs, including surgical masks, shield, gowns, and gloves. Next slide, please, Mitchell. Coming to sleep labs, people across the country are worried. There already was a huge backlog in sleep care even before COVID-19 started, and with the onset of COVID-19 pandemic, this has only worsened. So the key concerns in polysomnography, which we realized, were that BiPAP and CPAP actually are deemed as high risk because they can aerosolize the virus. The other issue is that the patients spend extended amount of time at the facility during testing. So this is not a face-to-face visit, which can be over in 30 minutes, a procedure which could be completed in 30 to 40 minutes. These patients spend their entire night, sometimes during the next day, if it is an MSLT testing, under that facility. So the damage could be widespread if that patient is missed. And most sleep labs and centers, by nature of the expertise, accommodate both pediatric and adults in the same facility. That's somewhat problematic because we all know that pediatric or children population are carriers more than they suffer from the disease, but they can easily transmit that to older population who can have devastating impact of the disease. Next slide, please, Mitchell. So we recommend opening of sleep services. I'm not going to, address the clinics in this way because the clinics is very similar to what we had addressed earlier during the talk, which was combined for pulmonary and sleep. But I'm going to focus on the sleep lab per se. And we recommend that we open the sleep lab in a phased manner. In the first phase, we recommend we just start with a home sleep apnea testing, or EDSAT as it's called. We prefer that these devices should be mailed rather than picked up by the patient at the sleep center, and similarly should be mailed back. And once the devices are received by the sleep lab, they should be isolated and not opened up for at least 72 hours because of reports that the virus can exist on surfaces, plastic surfaces, for up to 72 hours. And only after that, they should be opened up and they should be immediately disinfected. We recommend using of EPA-registered disinfectant products for cleaning. There's a list of EPA-registered disinfectant easily available on Google. And fortunately, majority of the cleaning disinfectants recommended by EPA are very, very simple and effective in eliminating COVID-19 virus from surfaces. Next slide, please. Second phase, we recommend that once we got a good handle, and again, we recommend it for 14 days, although we did not put that in writing. And the reason was that in areas which have very low prevalence, we think that this could be concurrently started. The second phase could be started along with the first phase. But I think in areas which there's high prevalence, we recommend that 14 days pass by, and then you have some feedback from the patients as to how many of them were converting positive before opening up the sleep lab to actual diagnostics studies. So in the second phase, we recommend only diagnostic studies, which is polysomnography studies. And we also recommend that this testing should begin with 50% capacity, one for physical distancing, and more importantly, for acclimation of the new workflow, which the technicians have to learn, adapt to, which slows them down tremendously, especially the increased use of PPEs. We recommend that all mattresses should have plastic covers, which can be much more easily cleaned and disinfected with the EPA-registered disinfectant. And then we also recommend that all room surfaces should be cleaned between patients using the same disinfectants. Next slide, please, Mitchell. Pediatric sleep studies, as we understand and we acknowledge that children are more asymptomatic carriers than actually symptomatic. So that could be problematic in a large sleep center. So we recommended that children mandatorily be tested for SARS-CoV-2 test within 48 hours of the study. And similarly, any accompanying family members should also be tested because in majority of the cases, pediatric cases are done with the family member staying in the room along with the patient. So it's very vitally important that both of those are tested and ensured that they are negative for the virus. Next slide, please. The third phase we recommend is starting the PAP titration study. And this is the final phase, and we think there should be a very strategic introduction of PAP titration, since this is the procedure which can aerosolize the virus and spread it. We recommend that full PPE be used by the technician, and the technician be trained again in the donning and doffing procedures and certified, and use of N95 mask or PAPR devices, face shields, gown, and gloves is mandatory for this procedure. Patient to technician ratio should be 1-to-1, mostly because they have to go inside the room several times for either adjusting the mask, changing the interface, so on and so forth. A portable HEPA filter in the room should also be considered. And we also recommend using non-vented mask with disposable expiratory ports and an attached HEPA filter for further reducing the risk. This is sometimes difficult for some people to understand what I'm talking. So the next slide, I will be showing you how this is accomplished. Next slide, please, Mr. So here's two publications, one by Krieger from Johns Hopkins and one from our group here in Morgantown. What we did was, generally when we have a mask, a face mask which we are titrating, they have few holes on it for ventilation because we don't want the CO2 to accumulate, which could be dangerous. But when you have a non-vented mask, with these holes actually can be transmitting the viruses, so we don't want a mask which is ventilated. So if we convert that mask to a non-vented mask, then you have to do a few things in order to make sure that you have expiration and a fully ventilated system. So as you can see, it's a little bit complicated in the picture, but you can see there's a flexible safety valve, Fisher and Paykel safety valve, which is basically an expiratory valve. And there's a bacterial viral filter breathes in and hopefully traps all the viruses and reduces the amount of transmission in the lab. On the right-hand side, you can see our contraption. You can see there's a hose, and that hose is connected to the HEPA filter, and that HEPA filter then connects to that non-vented mask, and the patient can undergo safely CPAP or BiPAP titration. In our contraption, you may see something called HME, which is a humidifier. You generally don't need this humidifier for a one-night test, and that can reduce the amount of bulkiness of this process. This was designed more for hospitalized patients where we were converting non-invasive ventilators into ventilators for sicker patients. So this is one way to reduce transmission or aerosolization of virus in our sleep. Next slide, please. Uh, if in-lab CPAP titration studies cannot be performed, or when you are doing surveillance, you find that there's increased rate of transmission in your facility, we recommend that you switch to auto CPAP titration at home and then remotely monitor the PAP titration data, and you can adjust the titration pressure based on that remote monitoring data. Next slide, please. So who should be prioritized for the testing? We think that patients in the backlog who are at high risk for adverse outcomes should be prioritized. And these are patients who are narcolepsy, fallen asleep behind the wheels, patients with REM behavior disorder who can hurt themselves or their family members, patients with hypoventilation syndrome. These are patients who keep getting currently admitted to the hospital for hypercapnic respiratory failure. And it's important that we reduce these readmissions and bad outcomes. Patients with underlying heart failure and COPD may be particularly beneficial from getting them prioritized for this testing. Who may be at high risk for this kind of test? Well, we certainly want to discourage pregnant women, elderly, patients who have underlying cancer or other serious, like somebody who's got transplant, immunocompromised, and then cautiously assess the risk and benefit of how this patient may benefit from here, or this patient may benefit from just a home sleep testing device and treatment subsequent to that at home. Next slide, please. Again, we are re-emphasizing the surveillance program, that any sleep lab, that they continue to monitor the symptoms or COVID positive status of these patients up to 14 days post-discharge or post-study test. And this, again, periodically should be critically assessed for success and for resuming sleep lab, and would be very helpful in dialing up or dialing down the services. So this is an inherent mechanism built in with our system where you can go from phase 3 and dial it back to phase 2 as soon as you feel uncomfortable, or as soon as the comfort level is reached, you can dial in from phase 2 to phase 3. Next slide, please. Next slide on pulmonary rehab. This is again something which is conducted in a group therapy. So we feel that this is high risk for transmission of the viruses. So we recommend that while the surge is going on, or the cases or case reports are going up in the community, that consider home pulmonary rehab. For home pulmonary rehab should obviously contain all essential components of exercise, training, education, and behavioral change. If center-based pulmonary rehab is opened up, we recommend the patient should undergo the similar screening and testing strategy as we have delineated earlier in the elective in-person services. Of course, social distancing should be maintained during sessions. We recommend that surgical masks be used by both patients and staff during the educational and the behavioral sessions. But as soon as exercise session starts, the staff should switch over to a proper N95 gloves and gown in order to protect themselves and from transmitting the virus. And only very necessary equipment should be kept in the training area, because equipment can easily transmit the virus from one person to another person. Next slide, please. So coming to the end, take-home messages, we want to ensure that these recommendations are tightly related to the downward trajectory of new cases in the community, and tied and aligned to your community and your institutional resources. So that's a very important component of it. I can tell you in our institution in the beginning of March, when there was a bigger pandemic crisis, all of these resources were redirected from ambulatory settings to in-hospital settings. So we lost all our PPEs from the sleep labs in the clinic and they were all taken to the hospital because it was so short of PPEs. So there has to be some accommodation for your local resources, how many people you have to take care of non-COVID patients, how many resources you have for testing and PPEs, and the entire thing should be structured regarding the prioritization on the basis of patient's acuity. And it should be a multi-phase screening schedule that we recommend. And very important to build in the surveillance program and assessment of the operation, because you don't want to be operating in a silo. You don't want to be the nidus of the spread and be totally ignorant about that process going on. If your institution, if your medical center has a rate higher than your community, your state, or nationally, then that's time to take a deep breath and say, what am I doing right and what am I doing wrong, and how to reassess the situation. The task force believes that a static plan is unlikely to be maximally effective in the context of a very dynamic disease and transmission, and the operational strategy should be frequently assessed and modified as needed to emphasize strengths and correct faults. So thank you very much for your attention on a Monday morning, and hope this was helpful to you at the other end.
Thank you so much, Dr. Sharma. That was excellent and super informative. So I wanted to open it up to some questions. Anyone had any questions, comments, thoughts for Dr. Sharma? Got some great things going on in the chat as well. Thanks for that, Dr. Doyle.
Yes, Mitra, hi, this is Sam Giordano. I'm a retired respiratory therapist and chair of the US COPD Coalition. Sorry, I had my mic screwed up on introductions, but excellent presentation, Dr. Sharma. Question with regard to testing. In terms of the PrEP, you indicate a negative test of two tests more than 24 hours apart. Could you give us a little more detail on that more than 24? I suspect there's an outer limit, but there's also a minimum. So my understanding before the talk was, well, if you had two back-to-back negatives 24 hours apart, that was good. But I get the feeling that when you say more than 24 hours, you're really asking for something a little more than that. Would you comment, sir?
So I think in essence, you are correct that the idea is that they shouldn't be that close to each other that the second test doesn't validate, because, you know, the problem with these testing and retesting is that there are many different types of molecular tests, antigen tests. Some of them have better sensitivities than others. And it also depends on the prevalence of the disease and the virus in the community as to the false negative and false positive rates of these tests. So it's critical that we don't have the tests too close to each other, which would, you know, fail the purpose of reintroducing a healthcare worker into the medical community and causing transmission. So I think we are saying that the test should be at least 24 hours apart and not closer than that. So I wouldn't go and get a test this morning and then get another one at 5 this afternoon and consider that as a negative. So what we are basically stressing on, and I think this is a good point because I think this reiterates the fact that when you have two tests, which are, then your chances that this is a false negative test are much lower than otherwise. And I think that's what the basic sense. So I think you got it right in the first place, and I just want to reiterate it.
Thank you. If I could have just a quick follow-up, and then I'll get out of the way for others. Would you give us a hierarchy of preferred tests, more starting with what you think is the most precise and work on down the food chain?
So, you know, as far as the data that we have, as far as the literature that is coming out. And again, just like anything in COVID-19, everything is a moving target. So I think our best bet still is the molecular test, where we actually checking on the mRNA, and then these are complicated tests because, you know, when you get a swab back, these undergo a lot of processing, including cycles of heating and cooling to change the mRNA into a DNA, which is what is actually detected in these tests. And I think these molecular tests, again, there are, again, many different ways to do this. So different labs do it different ways, these molecular tests too. So there's some variability in that too. But I think in the top of the hierarchy is this molecular test, which I think is as far as we are concerned, the most reliable test we have so far. I think the second on run is the antigen test, which obviously detects the antigen, but again, it has more false positive and negatives compared to molecular testing. And I think the last one in the hierarchy is the antibody test, because as we know, many patients don't create antibodies or may create antibodies much later than before. And sometimes it doesn't even give you an answer whether this patient acutely ill or had it in the past. So I think if I were to consider, and specifically what we are doing right now for having the workforce been reintroduced, we only doing molecular testing. Okay.
Thank you, Dr. Sharma.
Thank you. So we had a question in the chat saying, so when you referred to tightly connected to downward trends of cases in the community or community prevalence, they were just wondering if you had some examples of how to assess that data using the West Virginia DHHR COVID data online.
So yes, this is a great question. And again, it's a little confusing because what we don't want to do is tie our operations to false data. And the problem comes in, are able to access more study kits. As we're able to ramp up more studies, then yes, we're going to find more new cases, but that doesn't mean the rate is going up. And I think that's where the dichotomy comes in when you do daily cases, which may go up and down. And CDC recommends that we follow this trends for 14 days and we take a mean average. And the basic principle is the number of tests should remain the same. So that's the premises. That's why we believe that a surrogate marker like hospitalization should be used. That's a very easily available data in both institution as well as West Virginia. You can even Google it, how many patients are right now in West Virginia, and track it down on a daily basis. And if that is continuing to go up, we feel that's not the right time to ramp up these phases. So the dial-in phase 2 to 3 is basically dependent on these rates, which are your local state rates. If you can align your operations to the state rates, then you actually are doing much more favor to these patients, either reducing the exposure or reducing the backlog if that is the case. So this alignment is very important. And of course, the bigger alignment than that is, do you have the resources to take care of those patients? And number two, how do you prioritize those backlog patients? So I think that the pillars to a successful non-COVID operation opening up would be these three: is tying up with your rates of your state, especially the hospitalization. Number two, prioritizing who's the sickest and would need immediate attention. And number three, what are the resources? How many PPEs do I have? How many doctors, nurses are there in circulation so as to take care of these patients? So I think that's the dynamic nature of this recommendation.
Excellent, thank you. Dr. Doyle?
Thank you, Dr. Sharma. I don't think we have time right now because we're 3 minutes from the hour, but but maybe at our next or our next few ECO CLD sessions, I would like to actually do a lab on what Dr. Sharma just said because I don't think it is that easy for us in the primary care settings to calculate those rates. I don't think our literacy with these rates that he's talking about and going and accessing the data is where it needs to be, so that we'll really do this week by week. I think we need some practice. And if we had another 20 minutes, what I would ask us to do right now is screen share the EHHR COVID site. And for example, tell Tara Morris and Alice, help Tara Morris and Allison Seela know how they're doing in Preston County, and have Dr. Sharma tell us how you all are doing in Monongalia County. I think we need that kind of practice to really use this.
Definitely, Dr. Doyle, thank you. Like you said, since we just have a little bit over a minute, or just a minute now, maybe next time we can schedule actually going to the website and screen sharing and calculating those actual numbers. So
we could do that in the next session.
Yeah,
Sure.
great idea. Thank you. Any final thoughts, comments, questions? I always feel that the hour goes by way too quickly. All right.
I would hate us to end without somebody, and I nominate Grace Ann, to talk about a home pulmonary rehab app that some of us are involved with, in terms of the recommendation of the task force about home-based PR for people at greater risk.
That's an excellent question. We can address that too, the next one.
Absolutely. Sounds great. All right, guys. Thank you so much, Dr. Sharma. That was an excellent didactic. And thank you all so much for joining. Just one quick housekeeping announcement. Our next session will be on August 3rd. And David Weissman will be providing our didactic on co-workers' lung disease. So keep an eye out for that reminder. And we'll see you all next time. Thank you, guys.
Thank you.
Thanks. Bye.
Thank you. Goodbye.